Thank you very much for the invitation to this conference. This is a subject that is very close to my heart, the issue of radiological protection, of patients' radiological protection and staff radiological protection. I will focus on that in my presentation, but I will give you just a brief background of who I am. I am an interventional radiologist, and I perform procedures every day, sometimes 7 days a week, between 1 to 7 or 8 procedures a day. So the exposure is really huge. So I'm very much interested in your presentations and in your opinions, in your questions that I hope you will address to me. I will present you my point of view of how I see radiological protection in my lab, in my department. I will give you examples of the procedures. I will tell you how we are coping with the problem, because I believe that the current methods of protecting, especially physicians and the general medical personnel, are not sufficient. I will provide some evidence for that claim, but it will come. I hope I could share my screen with you. Okay, so ladies and gentlemen, the main body of my practice is taking place in cooperation with Professor Jerzy Walecki from the State Medical Institute. And as I've already told you, I will present my personal view on interventional radiology. The slides will be in English and I'll be speaking Polish. What are we afraid of as physicians, as doctors, as doctors performing X-ray guided procedures? What are we afraid of in relation to this radiation? Well, of course, these are X-rays. And there are two types of radiation. Well, that's the main beam, which goes through the body of the patient, so we can see our tools. This main beam has its harmful effect, and scattered radiation, because we try to avoid the main beam, but scattered radiation is our main problem. So you can see examples from my practice. These are two examples of how we can harm a patient, hurt a patient while using the main beam, because we have to take care of the shield, also of how the body of the patient is placed on the table. So we can see temporal epilation, loss of hair on the left hand side, and on the right hand side this is a burn that appeared because of the anatomy of the patient, but also because of that was also sort of caused by ourselves. The patient was lying on the table, and there was a skin fold which produced this injury. It was quite a routine procedure, but unfortunately the patient got burned, and as you all know very well, these are deterministic effects of radiation depending on the size of the dose. Well, fortunately, that was just the only case in my practice of 15 years, and the patient was completely cured, so we saved his life. So anyway, he was grateful, but we need to take care of how skin folds are placed also in neuroradiological procedures. We have to be very careful about it. Well, these deterministic effects on skin show that that what we do depends on the dose and the time when radiation is applied. Of course, and we should work towards the reduction of the dose. Well, patients make a really very important part of the subject, but the main issue is ourselves and the medical staff, all people involved in interventional procedures. Well, a patient undergoes one or two or three procedures in their lifetime, while that's what we've been doing through most of our professional lives. And these doses, they come from quite an old publication from 2011, but I'm afraid that they are underestimated. So this exposure of an operator may reach 4,000 millisieverts. That is equivalent of 5,000 chest X-rays. That's the exposure that we get in a lifetime. That's what we are exposed to through our professional lifetime. Well, there are two types of occupational diseases linked with radiation. One relate directly to X-rays, and other, this is the second bar on the chart. They are connected with our with the body posture and with the fact that we have to wear all this radiological protective equipment, lead aprons, something that I'm sure you know very well, cataract, which in many cases is a disease that is quite common in older radiologists who were not wearing gloves or adequate personal protection equipment. So problems with vision are quite common to them. You can see here the chart which shows the prevalence of cataract development in medical staff, in physicians, and in one survey it was even concluded that almost 50% of interventional cardiologists develop this disease. Well, thyroid is very important because depending on the dose there are functional changes that may take place, and thyroid tumors are much more frequent in medical staff working with radiation. We can also, of course, hyperthyroidism or hypothyroidism. Well, risk on fetus, that's quite obvious. Well, pregnant physicians, pregnant members of medical staff shouldn't be working with radiation, although we know from practice that such cases happen, and they may have quite serious consequences on the fetus, and they may result in congenital diseases. Well, even low doses of ionizing radiation, but with regular exposure, may X-ray guided brain procedures, well, brain tumors which turned out to be much more frequent in operators, especially on the left side, where we are closer to the C-arm, to the source of radiation. Usually we are on the right of, we are placed on the right side of the patient. Neurocognitive decline. I think that all who perform such procedures know this feeling of fatigue after many procedures, when we have problems with sleeping and with concentration. I can observe it in myself. After some days off, when I don't perform the procedures, when I'm not exposed to radiation, then I can come back to working with full concentration. And one of my major motivations was this fatigue after procedure. So that was my motivation why I have started dealing with radiological protection of myself during the procedures, because this fatigue is some kind is very specific, and it's felt after a longer working with ionizing radiation. What I would like to convey is that we are using radiation during interventional procedures in a very different ways. The intensity is very diverse. What we can read in most publications that assess radiological protection, usually fluoroscopy, is the subject. DSA or subtractive angiography are less addressed, or rotational angiography or DynaCT, that is computed tomography, which is performed on the table after the procedure. They are much less addressed in papers in the publication. I will show you how we perform our procedures that may be of interest to you, because of course you know theory much better than I do, but on these photos you can see the setup in my lab, how we are trying to shield from the radiation. But you also should know that we use these different techniques. Fluoroscopy, which is addressed in all publications, but this is a fraction of what we are doing. Maybe it's a bigger fraction in terms of time, but after all, it represents a small fraction of the doses that we absorb. This is thrombectomy procedure. This is a fluoroscopy guided procedure. This is just the beginning of it. This is just a simple fluoroscopy. So navigating under just regular common X-ray equipment, we use a catheter, and you can see, well, we start with a micro catheter with a guider, and then the guiding catheter, so we can see on ordinary scopy. But that's just the beginning, because what you can see now, this is DSA, this is subtractive angiography, so you can see the left part. This is the brain, quite a common brain image, the clog which blocks femoral artery. So a small syringe is used, so the catheter is placed after the clot, and another DSA series is administered. So this is the second series platforms, and you have seen DSA and venous arterial malformation. So this is another type of angiography
acquisition and the X-ray control. It's very important. A dose is very high, but it allows us to reconstruct vessels in 3D technique. So this is where the malformation broke. You can see all the fine vessels. And we can continue the intervention. On the left-hand side, you can see a special navigation of the catheter. It's a kind of a DSA. So you can see how microcatheter is introduced. On the right, you can see the black matter inside the malformation. This is annex. This is something used to block the malformation, clog it with the microcatheter, and once the vein is occluded, the malformation is occluded too, and the treatment is over. This is rotational angiography that allows us to assess effectiveness of the intervention. So apart from DSA, when we perform complicated interventions, we also use rotational exams, so the doses are very high, but we need to confirm that the intervention was successful. The image you can see is a 3D image. This is the same malformation in the new apparatus I am using. We can actually use the 3D technology. It's another type of malformation. You can see not only 3D image of the vessels, but you can see the flow inside the vessels, which is a very spectacular feature of this new apparatus. So this is a huge complex malformation, and we can obtain 4D image. However, it increases the dose. You have to increase the dose if you conduct exams in 4D technology. I think that now you can imagine that what we know about the backscatter, radiation and radiological protection of personnel who are mainly involved in fluoroscopy during interventions. So DSA rotations or 4D technologies are not included, addressed. Another example, Professor Popiela yesterday was telling you about such interventions, but here you could. This is a result of a rotational image. So you could see DSA. It was an image of aneurysm. So this is a control DSA. So aneurysm was blocked. I'm sure that Professor Popiela told you a lot about such cases. It can look not very professional, the dosimeters you can see in this picture. Our standard shields do not provide us with complete protection. So these are this is a series of DSAs by 2 tubes. So outside of the floor zone, all the dosimeters show that the scale has been exceeded after the first series. We will talk about units in a moment. So this is just a comparative study. This is our standard shield we receive together with the equipment, and this shows you how we are protected by our lead aprons. Some of our skin is really affected. Significant parts of our head, hands, and legs, they are not protected sufficiently, so we were trying to think of some solutions. A rotational angiogram which provides 3D images. You can see the same dosimeters used. This is the interventional room. So a rotational angiogram is performed. So these are usually two rotations. So about 100 acquisitions are performed. So you can see the increase within only 5 seconds. So the increase is by 35. So if we look at it from the perspective of our control room, these are trace amounts of the radiation. So we would like to feel as confident as we feel working in our control room. We would like to feel safe when we are next to our patient's bed, and we wouldn't like to wear the aprons, but of course we have to. So this is an acquisition with the application of shields we are using at our work. So we have asked the National Center for Nuclear Research, we asked them for some professional measurements concerning the doses generated by our biplane apparatus. We also wanted to find out about effectiveness of the shielding provided with the apparatus. So manufacturers promise us that this protection is great to eliminate the backscatter radiation. So this is the dose measured by an external company, biplane, this DSA I have mentioned provides a completely different scale. I wanted to show you a comparison with fluoro radiation. So one tube is used. So when we are looking at this paper, we can see that it's a completely different scale. So we have decided that the shields provided by the manufacturers reduce our exposure by 25 times in comparison to working without the shields. We have also developed our own shields. So without the standard shields, the reduction is by 70-something times. So a lot of calculations have been made, and we can conclude that if we apply one shield, the shield we have designed ourselves, then we can perform 78 interventions, and the dose received will be the same as one dose we receive using the standard shields provided by the manufacturers. So I think we go in the right directions. We would also like to still improve this result. You are experts in radiological protection, so I wanted to show you different applications used for different acquisitions where the doses are completely different. So the publications, the results published really have to be reanalyzed, and some new standards should be developed. This is a comparison of the highest value of acquisitions. I mean the DSA acquisition. Sometimes in thrombectomy we managed to make only one acquisition. I have performed such interventions. However, usually there are more subdural hematoma. Actually, this intervention requires administering small amounts of contracts with aneurysm embolization. We probably need some free acquisitions, but there are some interventions such as vascular malformations require numerous acquisitions, for instance 52. So if we see the reading in grays or DAVFs, it cannot be really interpreted into the dose we actually receive. The table you have seen, the table with a high DSA dose. So when I perform an intervention, I stand on the right-hand side of the patient behind the shields. I would like to tell you that in different procedures we use different numbers of the series, and we need some standards for this. This is another example of vascular malformation that has been embolized. So lots of acquisitions were required. Finally, we managed to occlude the malformations completely. So on the one hand, you can see there were DSAs, but we also needed 4D acquisitions for this patient. And very high doses had to be administered. I also wanted to show you a completely different type of intervention. This is a venous embolization. Usually, we use our hands to reach the embolized arm. We embolize vessels in pelvis or in abdomen. So this shield is completely different. This setup is adapted to our needs. You can also see a fragment of the apron added to this shield because we were making some measurements. So this part of the shield in this geometry has protected us rather well, but in this fragment actually there were some leaks. So simple solution to improve operators' safety. To sum up, for different procedures, especially in interventional cardiology, high doses are used. There are lots of different technological solutions in the form of shields. We don't have time to talk about this, but it has to be individualized, personalized. It has to be measured on the spot to improve protection of patients and staff. I have conducted some 1,500 of such interventions. You can see here in the corner the doses of some 20-30 milligrays. In neuroradiological interventions, sometimes we can see 5 to 6 grays. And if we have the protection, we will be able to conduct more such procedures. So the staff are exposed to high doses of radiation. Thank you for your attention. If you have questions, I will be happy to answer them. This is our setup, the setup I have designed. So this wall was added, so radiation is reflected from the walls, from the ceilings. So we are going to work on this in future, and I hope we will be able to cooperate with you to improve the safety of patients and our safety. Thank you for the presentation. Thank you. The first comment from me, if I may start. I am happy that medical personnel have this knowledge, are aware of the radiological protection. They know that ionizing radiation is an undesirable factor, at least in the occupational radiation. But radiation is necessary for the patient. One comment to your presentation. I would like to stress, I would like to make it clear that the work in occupational exposure is mainly based on the system of limitation. Correct me if I am wrong, but effective doses to the interventional radiologist very seldom exceed the values that would qualify you to a exposure work. I understand that the readings you were showing in your presentation are significant values. However, not necessarily they indicate the actual exposure to the interventionalists. So the procedure, the optimization of radiological protection to the staff is a good direction. It's a good direction concerning good medical practice we discussed yesterday. It also includes exposure to ionizing radiation. So this is a synergy between these two elements. So thank you for presenting this approach in your presentation, but I would like to stress it's the same for about tumors. If we are talking about deterministic effects you have mentioned, yes, we have some deterministic effects. It's beyond the discussion. But when it comes to tumors, they are a part of daily life and death. So, to be sure that we know of the reason, we need detailed epidemiological studies. So, as far as I know, the levels of the doses to the staff, we shouldn't expect such effects. I'm not saying that we cannot expect, but they do not have to occur. So if you could answer me, if you would like to comment, please do.
When it comes to the real life scenario, our dosimetric measurements, well, the official ones, were performed using PLD dosimeters, and there is a 0-1 sort of response. So on many occasions we found the excessive doses in situations when they shouldn't take place. I don't find them really particularly reliable. TLD is calculated in one spot, but the exposure for the whole body is just estimated. But with artificial intelligence and machine learning at our disposal, we can quite accurately calculate the exposure of our medical staff to scattered radiation doses. In many labs, people don't use TLD dosimeters because they provide results after very short exposure time. And then people were often surprised. But I think that this should be upgraded, the way that these scattered doses are measured. well, correct me if I'm wrong, maybe you know some papers or publications, but I just know a handful of publications on scattered radiation in case when bipolar equipment was used. I'm sorry. And it doesn't look, as we can see that on the figures, that there is a tube, scattered radiation, and that's. And in many publications, we can read that the shorter operator receives smaller dose, while we know that people who are taller, they are more exposed because at the top the dose is more concentrated. Well, and we have to find out where this radiation gets, this scattered radiation. Well. That's something that is very interesting, but that's also my response to your comment, because I believe that that our exposure is underestimated, and the impact on our health is an issue that most people get interested in. And thank you. Yeah, of course, that needs a lot of discussion, in-depth discussion.
I would like to ask Zhenya for comment. Comment to your presentation.
Yeah, thank you very much, Dr. Zawadzki. It was really interesting, and it was very good to listen to interventional radiologists being aware and being interested in radiation protection. Very good, I think, practice. You have shown very good practice. My comment is on the dosimetry, because for interventional radiology, and I will show this in my presentation in a few minutes, the recommended dosimetry approach is with double dosimetry, because under apron dosimeter, the main dosimeter for the whole body, is definitely not enough, because what is really of interest is the exposure of the parts of the body that are open, like the head, the eyes. Double dosimetry means one dosimeter under the apron and the second dosimetry at the collar level or at the eye level. If double dosimetry is not possible, the international guidelines recommend one dosimeter but placed over the apron. Of course, it depends on the legislation in the country. I don't know what the Polish legislation requires, but these are the international recommendations. So, and of course, there are new developments, as you mentioned, with motion tracking, with some software predicting the dose in real time. Of course, electronic real-time dosimeter have very good also impact on the practice. So you have shown many good approaches for improving individual protection, but I think what is also very important, and I'll try to mention this, to reflect this in my presentation, there are many other very small approaches, small things, very simple approaches for dose reduction that reduce doses to not to staff only, but to patient, because as you mentioned, the main source of exposure is the scatter from the patient, and reducing the primary radiation to the patient, this reduces also the scatter to the staff. So it's not just shielding. There are many other approaches, many other factors that can reduce scatter dose. But you properly mentioned that knowing the scatter distribution is extremely important, and I would dream to have all radiologists working in interventional being interested in this as you are.
Well, if I may, there are two comments or questions. I think there is a question as well from Agnieszka Kuchcińska. Good morning. wonderful presentation. My question is whether these measurements were made by the personal staff. Were you supported by your inspector for radiological radiation and inspector for radiological protection and or medical physicist? Was that on your initiative, on the medical staff, or your radiological protection inspector? That was my initiative. We have a company which produces such shields, and we paid them for these measurements. We paid for the measurements to the external company this was our initiative, the initiative of our, that happened on the initiative of our medical staff, if that is a satisfying answer.
I suppose Agnieszka's question was related to the use of which kind of dosimeter was used, because in interventional radiology it's extremely important what type of dosimeter is used. It should be sensitive to pulse radiation, it should be calibrated for the beams, otherwise the readings could be completely wrong.
Let me check, just 1 second, I will tell you the name.
No, I have no doubt. I'm just making comment that it's important how you choose the dosimeter when you perform dosimetry measurements.
Right. Yeah, that's a very important point, because we try to use many different dosimeters, and some of them are not sensitive for scattered radiation. And that one was thermoscientific FH4GL10. So this was it was working very consistently, and was chosen actually by the specialists.
We have another comment. The major problem are doses to lenses. Unfortunately, that may qualify medical staff to category 8. Well, one short comment concerning eye protection. Well, please note how glasses are shaped. There are many publications which show that the glasses that we are using are of little use, of little protection. And two more comments from Agnieszka Kuchcińska, both from Agnieszka Kuchcińska. Well, the one about exposure category A, that was the comment from Joanna Kidoń-Szołtysek. What I meant is that unfortunately radiological protection inspector only replaces personal dosimeters and doesn't take such a comprehensive approach as that of Dr. Zawadzki. And unfortunately, I also myself experienced a situation when the radiological protection officer didn't want to take care and didn't want to analyze the problems of radiological protection. He didn't want to go in depth into that. So a lot of respect to you, Doctor, for your comprehensive approach. Well, thank you very much. Thank you very much for your presentation. I hope that we'll be able to we'll have an opportunity for the exchange of views before 1 p.m. I hope you will join us. I'll do my best to be with you.